Good morning, everybody. I shall be talking to you about endothelial keratoplasty. I have no financial interest to disclose regarding this presentation. Endothelial keratoplasty refers to a surgical technique wherein healthy donor endothelium is transplanted into the recipient eye with or without the stromal tissue. And the advantage over conventional full thickness corneal graft is that you get faster visual recovery. There is no surface incisions or sutures, so the surface topography is maintained better. You have faster wound healing, you have greater tectonic stability, and reduced rejection rates. The different types of endothelial keratoplasty, you have DSEK, which is decimet stripping endothelial keratoplasty. You have DSAEK, which is decimet stripping automated endothelial keratoplasty. You have ultra-thin DSEK, and you have DMEK, which is decimet membrane endothelial keratoplasty. The steps of endothelial keratoplasty, the basic steps are you do a decimet stripping in the host eye to remove the unhealthy decimet membrane. You prepare the donor lenticule for transplantation, or you can get the pre-prepared donor lenticule from the eye bank, which is then loaded into the injector. You insert the donor lenticule or the donor graft into the eye and then position it in the desired location, after which it is secured in its position using air or gas tamponade in the host eye. The evolution of endothelial keratoplasty, it all began with the description of posterior lamellar keratoplasty or deep lamellar endothelial keratoplasty. Gerrit Melis from Netherlands played an important role in popularizing this surgical technique. In the initial surgical technique of deep lamellar endothelial keratoplasty, we used to dissect in the host cornea, make a lamellar pocket, and then cut out a posterior disc measuring 8 millimeter in size, prepare a donor lenticule in the same way, and then try to fit the lenticule within the space that we have created. It required a lot of surgical manipulations. Although the visual outcomes were good, it never really became a very popular technique. With the introduction of DSEK or DSAEK, which did not require any surgical dissection in the host eye besides removing the decimet membrane, the insertion of the donor lenticule and its positioning was far more simpler, and this procedure became popular worldwide and started replacing the traditional penetrating keratoplasty. Further refinement in surgical techniques led to the evolution of decimet membrane endothelial keratoplasty, which is just the isolated transfer of the donor decimet membrane with the healthy endothelium, which gives a perfect anatomic reconstruction in the host eye. And the second procedure was the ultra-thin DSEK, which comes very close to DMEK. If you look at the data from the Eye Bank Association of America, and if you look at the 2019 data, you will see that although traditional penetrating keratoplasty is still being performed, there is a gradual increase in the number of endothelial keratoplasty procedures being performed every year, and there is a rising trend for the number of DMEK procedures being performed. Now let's look at the different procedures. When you talk about DSEK or DSAEK, the donor tissue basically consists of the donor stroma, which measures about 150 to 180 microns, along with the decimet membrane and the healthy endothelium. In DSEK, the donor lenticule is prepared via manual dissection after loading the donor graft onto an artificial anterior chamber. And in DSEK, you are using an automated microkeratome to do an anterior lamellar keratectomy, which results in a much smoother interface. Ultra-thin DSEK is where your stromal tissue is thinned down to less than 100 microns, and this can be achieved by multiple passes with the microkeratome to achieve a very thin graft. DMEK is basically just the decimet membrane along with the healthy endothelium, and this is prepared by stripping the donor decimets from the donor corneoscleral rim. The donor grafts can be prepared by the operating surgeon. DSEK requires a manual preparation. DSEK and ultra-thin DSEK require the use of automated microkeratomes with various heads, which can cut depths from 250 microns all the way up to 400 microns. DMEK requires a manual preparation. In the Western countries, you have the eye banks that give you the pre-prepared donor tissue. For DSEK, you get for DSEK and ultra-thin DSEK, you get the pre-cut tissue. So the surgeon just has to punch out the donor and transplant it into the eye. For DMEK, they give you either pre-stripped tissues where the descemet has been stripped but not removed completely, or they can give you preloaded tissues where the descemet is stripped, punched out, marked, stained, and then loaded into an injector, and then provided to the surgeon at an increased cost. The indications for endothelial keratoplasty are basically any condition with endothelial dysfunction. The common indications we do in our clinical practice are pseudophakic bullous keratopathy and Fuchs dystrophy, but it can also be performed in failed corneal grafts, in rarer conditions like ICE syndrome, congenital hereditary endothelial dystrophy, endotheliitis arising from viral endotheliitis or toxic anterior segment syndrome. If you look at the surgical technique of DSEK, this is a donor lenticule that's been loaded into the injector with the endothelial surface facing up. We put a little bit of cohesive viscoelastic to protect the endothelium. This is moved forward to the tip, and then you put a little bit of an ink mark just to identify the tip so that when you are using your microforceps to pull it inside the eye. So you have an AC maintainer connected to the eye, which keeps the chamber formed. Now use a microforceps to pull the donor into the eye, and you can see it unfolds itself, and the AC maintainer is removed. And then you put a large air bubble under the graft to secure the donor graft in position. But before we do that, you have to remove you have to strip the host descemet's membrane. So here you can see under cohesive viscoelastic cover, we are going ahead and using a reverse Sinski or a specific DM stripping hook to break the descemet's membrane at about 1 millimeter diameter, larger than the size of the graft. And then you can strip the decemets away from its attachment. And keeping the pupil dilated against the red reflex, you can see the stripped decemets much better. The other way to remove it is to keep the anterior chamber filled with air, and then you can remove the decemets membrane. It gives you a very good contrast of the area from where the decemets has been stripped away. This is again just to show you, this is an ultra-thin DSEK been performed where the graft is quite thin, and it is not as easy to handle as a conventional DSEK graft. So here we have put a little bit of cohesive viscoelastic, and then we are kind of tri-folding the graft because it's because it's very thin. It doesn't have the rigidity like a DSEK graft. This is once again, it's loaded into the injector. So there are various types of injectors available. The popular one are the Bucin Glide. This is one which I use. This is from an Italian surgeon called the Macaluso inserter. You have the Endoglide. You have the Endoserter. So there are Endosaver. There are a lot of devices. So again, using the microforceps, the donor tissue is pulled into the eye. You keep holding on to it till it unfolds. You release the AC maintainer because you don't want the tissue to pop out of the eye. You place an air bubble below the graft, and this further opens up the graft. You see an S mark on the stromal side of the graft. So these kind of marks, whether it is S or P or F, it helps us identify the orientation of the graft. The other way is to look at the double ring reflex at the edge of the graft. That ensures that the orientation is the correct side. So this is the same patient in the post-operative period. If you compare the pre-op and post-op, you can see that there is a significant change in the corneal clarity and the visual improvement of the patient. In comparison for DMEK, the donor DM, because to improve its visibility, it's stained with trypan blue. And also the stromal side is marked in a similar manner to help identify the orientation. So the tissue can be flushed into the eye, or it can be also pulled into the eye, pretty much like a DSEK surgery, but the more popular technique is the flushing of the donor into the eye using a glass or a plastic cartridge. And here you can see that the donor has been inserted into the eye. This is the case of Fuchs dystrophy. Once the wound is secured, using a no-touch technique, just by surface tapping, you can get the donor DM scroll to open up. So basically, when you tap the surface, you create fluid waves in the anterior chamber, and the fluid waves, by their motion, help open up the graft. You can see the S stamp on the donor graft, which tells us that's the right orientation there. And you put a large air bubble, which secures it in position. So that's the preoperative appearance on the right side, showing you a pseudophakic bullous keratopathy, and the left side is the image postoperative. You can see that the cornea is almost restored to its normal anatomy, and you cannot even make out that any surgical procedure has been performed. So the basic differences between DSEK and DMEK is the donor preparation in DSEK tends to be automated, whereas in DMEK it's a manual technique. We tend to use donor be above the age of 50 years, because below that, harvesting the donor is a little difficult, and because the donor DM tends to scroll a little more, unfolding can be a bit challenging. The insertion in DSEK is either push or pull through. You can use various inserters or glides, whereas in DMEK it's like a no-touch fluid-based technique. Unfolding for DSEK, you require a deep chamber, use an AC maintainer. The donor usually curves towards the endothelium, whereas in DMEK, you prefer to have a shallow anterior chamber. The donor usually curves towards the stroma with the endothelium on the outside. In DSEK, you can do a complete air fill, and you can, even if you release the air, leave a 80% air fill, the donor sticks, a lenticule sticks better. Whereas in DMEK, you require the tamponade for a longer duration of time. And that's why some people prefer to use non-expansile mixture of sulfur hexafluoride or perfluoropropane. And an INFI-API is usually performed either during surgery or before using a YAG PI. This is basically to prevent any postoperative pupillary block. Although DMEK is the most sought after endothelial keratoplasty procedure, it's not the ideal choice in eyes with limited visibility, where you cannot see details of the anterior chamber. Vitrectomized eyes, which have very deep chamber, the unfolding of the donor DM can be quite challenging. Or complex anterior segment where there are large iris defects, or eyes with post-trab or with tubes or unstable IOL complex, they are not the ideal cases for DMEK. Or if your eye bank provides you with a younger donor tissue, where stripping or later on unfolding may be a bit challenging, it may not be the ideal procedure to do DMEK. So in all these scenarios, DSEK or an ultra-thin DSEK could be easily performed. The postoperative regime is basically you use topical steroids similar to what you use for penetrating keratoplasty. However, in eyes with DMEK, because the risk of rejection, endothelial rejection with DMEK is pretty low, after a year, you can switch over from regular steroids to soft steroids for DMEK. Follow-up in the first 1 week is important once the air or the gas bubble has reduced in size, to look out for any detachment of the donor graft, because there are no sutures holding the graft in place. If you have a high-risk graft or a complex surgery, you need more frequent follow-up visits to ensure that the graft is in position and does not require any secondary procedure. Donor dislocation can happen if there is inadequate support, if your air bubble has disappeared too fast, or it has gone into the posterior segment, or if there is hypotony, or if there is any external pressure, the patient rubbing the eye, or because of excessive manipulation, the donor graft has poor endothelial function, you can have the donor lenticule, donor graft not sitting in position. It can be displaced inferiorly, or there can be separation between the graft and the host cornea. In this scenario, this can happen even after DMEK as well, and it's more common after DMEK because of the elastic nature of the Descemet's membrane. And looking at the orientation of the scroll, you know that whether it's in the right orientation or not. So in both these scenarios, you need to do a rebubbling where repeat air injection is performed to reattach the donor lenticule or the donor graft. The outcomes of DSEK, the average corrected distance visual acuity varies between 2030 to 2060. There is an induced hyperopic refractive shift of 0.75 to 1.5 diopter. So if you're doing a combined triple procedure, combining DSEK with a cataract surgery, you need to adjust the IOL power accordingly. Otherwise, your patient may end up with a hyperopic refractive or a post-op. Because there are no sutures in the cornea, the induced astigmatism is pretty low. The average induced astigmatism was only about 0.6 diopters. The mean 1 year graft survival was 94%. Graft dislocation rate varied from 0 to 82% with a mean of about 14%. And it was more related to the surgeon's technique and the learning curve. Endothelial rejection was noted in about 10%, mean ranging from 0 to 45. The endothelial cell loss was quite comparable to what you see with penetrating keratoplasty. Although certain techniques like using the endoglide or using the Busing glide, you could minimize the endothelial cell loss down to about somewhere between 14 to 20%. In comparison, if you look at the DMEK keratoplasty, the DMEK outcomes, you find that a greater percentage of patients achieve 20/20 or better. Almost about 17 to 67% who are 20/20 or better. The endothelial cell loss is comparable to what you see with DSEK. Graft detachment is partial detachment is a little higher, on an average about 28%. It was 10% for DSEK. And the primary graft failure rate, especially in the learning curve, ranges approximately around 2%. So if you were to compare DSEK, ultra-thin DSEK, and DMEK, the visual recovery is the best with DMEK. It has the fastest recovery. Ultra-thin DSEK is between DSEK and DMEK. If you look at the hyperopic refractive shift, you get the maximum shift with DSEK because the graft is the thickest here. Ultra-thin DSEK induces a lower refractive shift, and you get the minimal refractive shift with DMEK. Endothelial rejection rates with DMEK are in the range of less than 2%. Ultra-thin DSEK also has a pretty low endothelial rejection risk, whereas DSEK has somewhere around 10%. In terms of the learning curve surgical technique, the difficulty, DSEK is pretty easier to learn. And ultra-thin DSEK, because it follows the same principle of DSEK, it's not too difficult if you already know DSEK. But learning DMEK is a totally different surgery. So if you're transitioning from DSEK to DMEK, you have to learn the whole surgery over again. Dislocation rates, yeah, it's the maximum with DMEK. So you need to have a closer post-operative follow-up. Ultra-thin DSEK, because the graft has stromal tissue, it's thin, it kind of takes best of both DSEK and DMEK, and the donor dislocation rates are lower. And if your DSEK graft is pretty thick, you can have dislocation, so you need to watch out for that. So basically, in conclusion, DSAEK, ultra-thin DSAEK, or DMEK are minimally invasive corneal transplantation surgical techniques for dysfunctional endothelium. Surgical techniques of donor insertion and unfolding have a short learning curve, and quick recovery, better refractive outcome, and lower risk of rejection, especially with the absence of sutures and suture-related complications, make the endothelial keratoplasty procedure superior to conventional penetrating keratoplasty. However, if you have eyes where, besides the endothelial dysfunction, if you have stromal scarring, stromal irregularity, then you may have to perform a conventional penetrating keratoplasty. DMEK is the ideal endothelial keratoplasty surgery. However, ultra-thin DSEK is useful in eyes not suitable for DMEK surgery. Thank you. Thank you for your patient hearing.